The latest news, updates, and more from the world of health and medicine. This is Medical Minutes with Wish TV's medical reporter, Dr. Mary Gillis.
So this study includes sites from all over the country. We've got 9 sites from the East Coast to the West Coast, the Midwest, and so on and so forth. And we study patients who've been immunized and those who haven't to better understand how well the vaccine prevents emergency department visits, how well it prevents hospitalizations, ICU visits, and even mortality. So it's an important sort of nationwide group to understand how the vaccines are doing here in the U.S.
So, right, the vision project for this this study was the nine sites.
Yes.
Do you know if they stratified by different conditions? I mean, the age group. I mean, imagine it'd be over 18 to 65 or 65 plus. Underlying conditions. So, how do we sort of break that down in terms of coming to a conclusion, but with a variety of participants in the study right. So how do we do that?
Sure. So we absolutely looked at a number of covariates, and we've been doing that for all of our studies. So we look at things like age and gender and race and ethnicity. And of course, it's very important to understand the comorbidities, the other medical conditions that people have, because we know that people with multiple comorbidities are at much greater risk for having more severe disease. And so we absolutely study that. In our natural immunity study, we actually looked at all comers, and the overall statistic there was that those who are unvaccinated but previously infected, are 5.5 times more likely to be hospitalized. So they're much more likely to be hospitalized for COVID-like illness. So the vaccine offers significant protection across the board. If we only look at those 65 and older, those 65 and older who had a prior infection but no vaccination were nearly 20 times, it was 19.6 times more likely to be hospitalized with a COVID-like illness. And we know that for a lot of reasons. As we age, we get more comorbidities, our immune system doesn't function as well. And so we would expect that vaccines are actually more effective in those people who have medical issues. Right? And effectiveness is a function of a number of things. It's a function of not only comorbidities, the effectiveness is a function of the incidence in a community. So the more cases there are, generally speaking, the more effective the vaccine is. So yes, we absolutely did look at age. We didn't see any significant differences by race, ethnicity, or gender. We did see, as we've been seeing with multiple studies, the Moderna vaccine actually conveyed slightly greater protection than the Pfizer. So Moderna exhibited a 7.7 times greater effectiveness. The Pfizer was 5.1 times more effective. Both of them outstanding, great protection. If you get either one of them, it's good. But again, we're still seeing that trend that Moderna generally conveys slightly greater protection.
Okay. Wow. I mean, this was a study. I would say I was just looking, at the sample size. I would say it was relatively small. What are your thoughts on that?
It was large enough to achieve statistical significance, and that's what we're always looking at, is to understand whether we have a sample size that is large enough. And when you say relatively small, what are you thinking there?
Well, small considering, yes, I know we need statistical significance, but in terms of clinical significance, real world impact on this, just your thoughts.
Sure. Well, I think in terms of real world impact, I'll just make this very specific. I have a family member with significant prior lung disease. I believe because my family member has been vaccinated, they are much less likely to be hospitalized. In fact, this family member, who is old and also has many comorbidities that puts them in the highest level of risk, actually got COVID after being vaccinated. They stayed at home. They had mild symptoms. Why did they have mild symptoms? And why were they not hospitalized, or even why, potentially facing death? Because they were vaccinated. Vaccines are good at not only preventing illness, but if you do come down with the disease, do contract the virus, your symptoms and consequences are significantly lower. So, in terms of what we saw in this study, we had, we looked at over 200,000 hospitalizations and to look for individuals to be included in the study. Of those hospitalizations, we got down to around 7,000 had at least one test, and we saw 1,020 hospitalizations among the previously infected, and about 6,000 hospitalizations among those for COVID-like illness among those who had been vaccinated. A lot of folks have asked, well, wait a minute, you only saw 1,000 hospitalizations in the previously infected, but you saw 6,000 among those who had been vaccinated. Well, this is why, the details are important, and there's complexity here. And if you don't pay attention to the details, you miss the story. So among those more than 1,000 people, a much higher percentage of those individuals were hospitalized having COVID. Among the 6,000 that were hospitalized with COVID-like illness, that means it had symptoms that could have been COVID, a much lower percentage of those people actually did have COVID. And that's what's important to understand here, is that so people who are older generally have more respiratory symptoms just naturally. And so we're seeing lots of other reasons why people are hospitalized with respiratory illness, with respiratory disease, but fewer of them proportionally are due to COVID. And so I think all around this study provides good evidence, and I think reassurance that the vaccine is making a difference above and beyond what natural infection does.
Well, I like how you put that, Dr. Rennis, right? There's a story here. We need to show the whole picture. And hospitalizations could mean a number of things. Are they on ventilators? Or are they, it could be just a number of ways in which we can define hospitalizations.
Right.
So, but are we talking about just these these hospitalizations? Is that the only outcome in this study, or were we also looking at antibodies and T cells and B cells?
Yeah, we did. Yeah, we did not look at the humoral immunity. We didn't look at the antibody levels. We only looked at the clinical outcomes for those who are vaccinated and those who are not. And the primary outcome in this study was hospitalizations. We focused with laser-like attention on that.
And, I want to turn to this recent study about Israel study, shows natural immunity that delivers 13 times more protection against breakthrough cases compared to COVID vaccines. So this sample size was 10 times the size of this study from the CDC. They had three groups, right? Those who were vaccinated, those who were unvaccinated, previously infected, those who were previously infected, and then had a one shot of the Pfizer. So it's the same vaccine that we are using in the United States. This is just very confusing to me.
Sure.
Comparing these studies. I don't think it's not really,
Yeah.
apples and oranges. I can't say it's that, because we are using the same. And we just don't know yet what's happening. So I guess the information from both sides is important to just get out there. And it can
absolutely.
be confusing. Yeah, it can be, of course, confusing. But your thoughts on this study?
Sure, absolutely. So many people are familiar with the Israeli studies that showed the opposite of what the United States study showed. And I'll give you the headline first. I don't think it's clear why the studies showed two different results. They may both be valid studies. I was not involved in the Israeli study, though I've certainly read the paper and studied that. They're not exactly an apples to apples comparison. First of all, the United States has a different distribution of population, different comorbidities in the spectrum Israel is a younger country. So there's a number of different demographic factors that are different. The study method that both the United States and the Israeli study used were different. We used something called, here in the United States, a test negative design. That is like a bit like a case control. It's a de facto case control design. The Israeli study used a cohort design,
and it
which
was
is
sort of retrospective observational study. So that's not something. I'm sorry. Scientists, I love this. I just want to say, I didn't mean to interrupt you, but great point. Get right there. The demographics are different between these countries. Yeah. We've had things, Israel has managed the coronavirus in certain ways when the United States has managed it in other ways. So, yeah. I mean, right. I mean, it's not an apples to apples. Great point.
Yeah.
And so anyway, please continue. Thank you.
Absolutely. And I mentioned earlier, vaccine effectiveness is a function of a person's comorbidities. What we're seeing in our study time and time again, those who are older with more comorbidities, the vaccine effectiveness is greater. Why? Because they're at greater risk. So anything that can help prevent that is going to significantly do better. So I think those demographics make a difference. I think that the study design can make a difference. Now, also, there were actually fairly small numbers in the Israeli study. There was only, in terms of hospitalizations, our outcomes, we saw thousands of them. In the Israeli study, they saw 1 hospitalization in the natural immunity group and 8 hospitalizations in the vaccinated group. Those are very small numbers. And so, again, I think this is the way the scientific method works. We follow as rigorous a protocol as we can. We describe what we observed and how we observed it, and we contribute to the body of knowledge. We're going to get more and more data. And I think over time, we will better understand why the Israeli study showed one thing and why the United States study showed another thing. From my perspective, given that the United States study, the study that I was involved in, covered this population, the population that you're going to be speaking to, that we're speaking to now, I would prioritize those findings over the Israeli study for a couple of reasons. One, we're talking about our demographics. 2, I understand the method that we used better than theirs, right? And so from a demographics and a methodology perspective, I would prioritize the findings in the United States right now, not discounting the Israeli study at all. We need to keep understanding it and hearing what the Israelis have to say as they generate more data. But again, I think it is possible that both are legitimate findings, but maybe we'll get additional data as time goes on to better understand what triggered or what informed those differences. But I'm confident, and I stand behind the results that we have here in the U.S., that vaccination is superior to natural immunity in terms of preventing hospitalizations for COVID-related illness.
Well, Dr. Rennes, I love the way that you put that in terms of we have this study. They weren't conducted in the same way. And then also, it's not about a dispute. It's just adding to the body of evidence. And yes. At times I think that, I'm hoping that these can be conversations among scientists, yes. Not sort of a dividing people or individuals. And then when we give them the message, out there that what's happening, it's the message. It's not sort of a division between like I've already, yeah. I don't know. That's just sort of the way in which conversation is important between the scientific community instead of competition.
Yeah. And I when I have conversations about this, because obviously everyone cares about what's happening with COVID and the vaccine. Everybody, has a perspective. When I share information with you, I'm trying to share the facts as I see them, because that's what science does. There is a difference between the facts, the evidence, and the policy. And I am not talking about policy. I'm talking about facts and evidence. I believe the evidence is very clear that for those above the age of 18, there is every reason to get the vaccine. I'll go on record saying below the age of 18, because vaccine effectiveness is a function of disease prevalence. When disease prevalence is low, there actually are other risks for children getting vaccines. When disease prevalence is high, like it was a few months ago, absolutely we should be vaccinating children, but we can't predict the future. Are we going to see higher prevalence with COVID again? If you think so, then it makes sense to vaccinate your child. If you believe that we're never going to see another wave of COVID again, then it doesn't make sense to vaccinate your child. I just don't think it's very likely that we're not going to see COVID again. But the decision-making process here, the decision-making process that every individual has to go through is complicated. I think we're oversimplifying this discussion. I think the facts are pretty clear. Study after study have shown the vaccine is effective and it's safe. The question is, what do you do with that information and how do you implement policy? And I am not speaking to policy. I'm speaking to the evidence.
I mean, the facts on the ground. That's how I say it.
Yeah,
That's how I'm not pro-vaccine. I'm pro-science,
Yes,
and the
yes.
science points to, all the evidence points to a yes. In terms of, gosh. So, and then, I want to just ask you, so you're, if I heard, of course we have these rollouts of 5 to 11 years old, getting the vaccine. And, I once spoke to a doctor, he said, vaccinating kids is not going to end the pandemic. And I was looking at the study of the 3,000, it was about 3,000 kids who had gotten the study. And it looked to me more of like a safety protocol. And we know a vaccine can't be effective if it's not safe. So can you, gosh, I don't really know where I'm going to this question.
Yeah.
Can you speak to that? I just had a trouble understanding, that study in terms of it. Well, okay, it's safe, but is it effective? And if it's not effective, then they're not going to get other people infected. And the way in which I guess the CDC had presented it was like, this will save millions of people, or it will protect the children. But I'm not sure it's really about protecting the children. And this is just, and based on the readings of what I read. And so what I'm saying is, if it's safe, okay, minimal side effects, but if do we know if it's effective yet? And if it's not effective, then how can they spread it?
Sure. So, to get FDA approval, there's 3 phases. The first phase is just basic safety, ensuring that it doesn't cause more illness than it's intended to prevent. The second phase is really looking at dosage, establishing the safe level of effective dosage. The third phase are the studies that we generally hear about, which are the efficacy or effectiveness studies. Does it actually work? We know it's safe. We figured out the dose, the safe dose, and now we want to see if it actually has the impact that it does. That phase 3 data suggests that children are the vaccine is effective in preventing disease in children as well. And again, not surprising. They're actually using a lower dose with kids because kids aren't just mini adults; they're kids, and they need So what I've seen is that it's effective. Now, to the comment about vaccinating kids isn't going to end the pandemic, I'm not quite sure what point they're making, because vaccinating 65 and older isn't going to prevent the pandemic either, but we prioritize them initially, and so on and so forth. We do know that, at any age, you can be a carrier. And the really fascinating thing about COVID that I think, again, we still don't fully understand why. In the older age groups, COVID is much more deadly than influenza, much more deadly. In the younger age groups, it's less deadly than influenza. And there's this strange dichotomy going on. And so I think people are concerned about the potential for healthier younger people who aren't as impacted spreading the disease to those who are more at risk. And so will vaccinating children end the pandemic? Well, it depends on what you assume. If you assume that everybody else has been vaccinated, then very well, it may be the case that vaccinating children will end the pandemic, assuming everybody else has immunity. But I don't know that that's the case. And I don't know that I would make a statement like that. I think that we vaccinate for a variety of reasons. We vaccinate for personal protection. We vaccinate for the protection of others around us. And so I think there's more than one reason to think about in terms of the benefits. One of the other points I would make, and I think we have to go soon, is I sometimes make the economic
I'm sorry, you have to go soon? I'm so sorry.
Yeah, in about 5 minutes.
Okay.
The economic argument here is the vaccines are no cost. If you want to take a Merck pill once you have symptoms, that's around $700. If you're infected and you need the antibody infusion, the monoclonal antibody infusion, that's $2,000. And then if you wind up in the hospital, you're starting at around $20,000. So from the economic perspective, which would you rather experience? The $0, the $700, the $2,000, or the $20,000? Well, for those people who have life insurance or other type of protective insurance, that vaccine is like insurance. It's insurance against it's about reducing the risk of bad things happening. And bad things sometimes are costly, and sometimes bad things are deadly. And you have a vaccine that's been shown to protect against both bad and deadly outcomes.
I love the way that you put it. It's insurance. I love that. That's great. Dr. Grannis, this was an incredible conversation. I want to thank you so much for your time.
Sure, you bet.
Learn more and get more with Wish TV. Online at wishtv.com. And when you follow Wish TV on Facebook, be sure to check out more great podcasts from the All Indiana Podcast Network now at allindianapodcastnetwork.com.